I'm hoping. Yes, recording has started. Okay. All right, so we're going to continue down the belly, and now we're going to do the right side of the belly. So we got the liver, the gallbladder. We'll touch quickly on hernia and like a slide or two on pneumoperitoneum. Really wanted you to know that information again. So the first thing we're going to talk about is pneumoperitoneum. So what do you notice, Nick, about this slide? Yeah, I gave it away. Sorry. Yes, perfect. There's my little guy. There's my guy. Great. So you can see the A lines right here. So the preferred location to find your pneumoperitoneum is really going to be the midclavicular line. And you are going to be just inferior to that costal margin. And you're looking at the area between the liver and the abdominal wall. And you're looking for these A lines. I'll talk about in a second, but there's a thing you can do called scissoring, where you kind of just push down and lift up, push down, lift up. And then the A lines should come in when you lift up. And then when you push down, the A lines go away and you back to see liver. Other signs of pneumoperitoneum can also be air bubbles. If there's like a viscous perforation from like say stomach or bowel. So you'll see free fluid and then you'll see air bubbles within that free fluid. So that's another example. Gotta get this out. All right, so this is that EPSS, which is your enhanced peritoneal stripe sign. So essentially this is what they're doing. They're doing that scissoring technique where you're pushing down, you lose the air and then you let go and then the air comes back in. And if you want to be really weird for some reason, you throw M mode over it and then you get this pattern where you see the A lines and then you get tissue and then A lines. So what do we, what?
It just sounds like a very unnecessary step.
Yes, I agree.
Looks like air leaking out of valve.
Yep.
Like surrounding the fluid.
Mm-hmm. Exactly, right. So you've got the little air bubbles, little white bubbles within that acidic fluid. So if you ever see white little bubbles in acidic fluid, start thinking about a perforated viscous. All right, what do we got here? Oh, just kidding. Yes, this is actually your video. If it,
Oh, it is?
yeah, if you recognize it. But you can see kind of right in here, right, that little stalk. Pause this and pull back. So you can see that defect coming from here as it comes up. And then you can see the bit of loop of bowel right within that hernial sac.
You. See it in Troy. You can find that.
So other places to look could be umbilical. Again, sometimes the linear probe is actually also really helpful for this because we're going to be, again, really superficial. And you're just trying to find the muscle layer and then look for that defect through the muscle layer. Herniated loops of bowel, they usually have a rounded target-like appearance. And then they have a hypoechoic kind of outer layer and then a hyperechoic inner muscular layer. And then, yeah, that was it. Sorry. You can also look for hernias along the inguinal canal. And then you essentially would find the point between the ASIS and the pubic symphysis. You're just above the inguinal ligament. And then you can just kind of follow the epigastric vessels and then kind of follow it down. This is from Pocus Atlas. And then here you can see there's peristalsing bowel. This is muscle, so like the rectus sheath. Here is the iliac crest. And so you can see there's a peristalsing loop of bowel that's above the musculature. And then sometimes if you come down, like depending on if it's an indirect or direct hernia. So if it's a indirect hernia, right, it's going to go into the scrotal sac. So you can kind of track it down. And if you see it going into the scrotum, if it's a direct, it'll obviously stop before the scrotal sac. So some signs of an incarcerated hernia, just basically everything that you're going to find with a small bowel obstruction. So you're going to find free fluid around it. This is going to be dilated. You're going to have, if you throw color flow on it, you'll get hyperemia. And then obviously you're going to get findings of a small bowel obstruction, right? Because the most common cause for hernias and some most common cause of small bowel obstructions and somebody who hasn't had surgery in their belly is going to be a hernia. So again, free fluid, thickened bowel wall, dilated loop of bowel. Any questions on hernias? Ways to improve your success is have the patient Valsalva. That'll increase the abdominal pressure and then that'll push the hernia out more. All right, cool. So moving on to gallbladder. I think we kind of all know how you do it. I really like this approach. I know Joey does this approach. The other one I like is infracostal. Sorry, not infra, supracostal. So you're on the ribs looking down. I find this one I get a lot of bowel gas in the way. And then when I do my gallbladders, I actually do both approaches. So I'll start here because I can always like 90% of the time find it in this view. And then I'll take this and then I'll just start to track anterior, trying to keep the gallbladder in my view as I sweep forward. And then I usually end up here. So I've seen it in both views, trying to just figure out which one do I get the better, like full-on view of the gallbladder. Again, it's an organ that we're looking at, so it's always going to be in two planes, so long and short. This one, deep inhalation, is a really nice trick, especially if you are infracostal. So if you're below the rib margin and just having them take a deep breath. Same thing with subxiphoid, it'll just help bring everything a bit closer to the probe. We kind of start with looking for that Mickey Mouse sign. No, about 15% of the time, this general anatomy with the hepatic artery on the right and the CBD on the left is actually flipped in some people. So best way is just to put the color flow on it and figure out which one. And then things we're looking for, right? So your typical signs for cholecystitis, we're talking about calculus. So it's going to be stones. You're going to look at the wall thickness. Again, you're always measuring it to between the liver and the wall and the gallbladder, because that's where you can get the clearest definition. CBD, if you can find it, again, make sure that you're throwing color flow, so you're not accidentally measuring the artery. And then looking for pericholecystic fluid. And then to do your sonographic Murphy's, if you're infracostal, then you can just push with the probe on it. But if you're to the side or supracostal, you can use your hand and then slide your hand up, and then you can actually see the gallbladder like moving as you're pushing on it. Sonographic Murphy's is thought to be kind of one of your better signs for cholecystitis with gallstones. So when you talk about what you need for the diagnosis of cholecystitis, it's usually going to be pain, stones, and then a sonographic Murphy's. And then if you get any one of these, usually these two, that's sort of just more fuel for the fire. Cholelithiasis is sort of a diagnosis of exclusion. So just remember that I think it's like 20% of the population has stones, doesn't cause any issues, and that may not be the source of their abdominal pain. So making sure that you're looking for other things, take a look at the liver. When I was a new attending, I had a lady who was very large, who came in postprandial abdominal pain, vomiting. She was female, she was large, she was fertile, she met all the Fs, right? She had gallstones, and I called the surgeon. I was like, it's symptomatic cholelithiasis. You need to admit her to your service. I can't get her to stop vomiting. She's not comfortable. And the surgeon was like, get a CAT scan. I was like, what do I need a CAT scan for? Like, it's her gallbladder. And he was like, get a CAT scan, call me back. I was like, fine. So I get the CAT scan, and it was an incarcerated umbilical hernia with small bowel obstruction. And it was literally just, she was so large, like you couldn't feel the hernia. And so again, diagnosis of exclusion. My general rule is if they have gallstones, but no pericholecystic fluid, no thickened wall, I don't get like a really good sonographic Murphy's on them, I will put that to the side and continue my workup like they don't have gallstones and potentially do the CT or whatever other stuff I need to do. And then if my workup is negative, then it'll come back to maybe it is your gallstones. But again, it's a sort of a diagnosis of exclusion. Got to make sure all the other bad stuff is gone. Again, just really nice Mickey Mouse sign.
What was that?
Yeah.
It was like it was just like wall, like it was like gallbladder, edge of the wall, every fluid.
It's yeah, it's a matter of playing with your twist.
Yeah.
Because you got to get that portal vein and cross section. All right. So yeah, so 15% of the population has stones that don't cause any issues. And again, the other thing to remember is that these stones back here are not the one that's causing the problem. So if they have stones, but you're not seeing one down by the neck or a stone in the neck, chances are it's probably something else that's causing their issue because it's the impacted stone down in the neck that causes it. When it comes to measuring gallbladder wall thickness, right, I always sort of wondered, I'm like, well, where do I measure in this picture? Do I measure here or am I measuring here? And so the answer is you measure both. You want to look at the thickest area and you want to measure that spot, not the thinnest spot. The other thing, I don't know if I have, oops, sorry, wrong way. I don't know if I have it, but when you fan through, right, the wall is going to get hazy because you're really fanned, and then it'll get nice and crisp. Same thing like when you do the pleural line and you're looking at the lung. So one of the things I always like to make sure I'm doing is trying to find where it is the crispest, where I make my measurement. And then again, wherever there's an area of focal thickening, you're going to measure that area of focal thickening and you're going to take note of that. All right. So what do we have here?
Gallbladder, there is some hypertrophic material, and it probably sludge.
Yep.
There's shadowing, like posterior enhancement. The wall that's thin, again, let's listen very close.
Yeah. So if this patient came in with right upper quadrant abdominal pain and fever, vomiting, what would you say they have?
Cholecystitis, right? Like it's a
Cholecystitis, yeah. Cool. What about this one?
this one, again, pericocystic fluid. Tell was the fast, maybe a stone, but it looks like it's at like the body of the gallbladder, not at the, like right at the end, right there.
Yeah, up at the top, you can see some stones.
Like it's in the neck, it's hard to tell. I don't see any like shadowing when they like scan through the neck of the gallbladder.
Slow it down.
For the wall, it's like very deformed.
Yeah.
There's just like a lot of pericles.
Yep. Yeah. So this was a lady that was admitted initially for biliary colic, was waiting a HIDA scan, and we just happened to be scanning her, and like this was what her gallbladder looked like. And I was like, I don't think you're biliary colic anymore. Right. And the cool thing was we were at, surgery actually came into the room to check on her as we were scanning, and they were like, oh, let's perhaps cancel that HIDA scan and we'll just take you to the OR now. All right. And then same thing, right? Another example, super thick wall. You got some pericholecystic fluid. And then there's a stone hidden in here somewhere. Actually, I think the stone is down in the CBD on this one. So just a little bit of an algorithm. Again, come in with right upper quadrant pain. If you don't see stones on the gallbladder, right, my differential is pretty large. I can essentially just cross out biliary etiologies. If I find stones, but there's no sonographic Murphy's, right, I'm basically back into this general area. If I've got stones and any other signs of cholecystitis, well, now I've got my diagnosis. And then the other thing you're looking for is if you can find the CBD, if it's dilated, now you're starting to think of cholangitis, choledocholithiasis, and then potentially getting into like cancers and stuff. The sensitivity and specificity for sonographic Murphy's is actually pretty variable. It's like 45 to 86%. And then ranges are like 35 to 94%. So it's one of those where if they have it, great. But if it's not there, it doesn't necessarily mean they don't have cholecystitis. Okay. So some pearls and pitfalls. What do you got here? It is the gallbladder. Yes. Why is the wall very thick? So what's your differential of a thickened gallbladder wall? Cool.
By these, you guys have.
Mhm. Think about its function. Yeah.
Yeah.
Yeah. Yeah. So that was essentially just an empty gallbladder, right? Yeah. So this is a postprandial state, someone who's just eaten. So some other differentials for a thickened wall, it's going to be pancreatitis. A big one is hepatitis. And I'll show you some examples of what the gallbladder wall looks like in hepatitis. It's pretty gnarly. Ascites, like you said. Other things, gallbladder cancer, adenomyomatosis, which we will talk about. Some renal failure can do it, cirrhosis, CHF, AIDS is another one, and then postprandial state. And so this is just an example of ascites causing a bit of a thickened wall and some pericholecystic fluid. What about this one? Exactly. Yep. So that's a common fake out is duodenum or empty initial like gastric antrum.
Yeah.
Okay. So what about this one? So there's a stone there. So this is one of the pitfalls of being undergained.
Is it in the neck?
It is in the neck.
See that
Exactly.
shadow?
Yep. So right here's your shadow. You can kind of see that. And if you notice in the gallbladder itself, you're actually seeing the little like folds
Yeah.
of the gallbladder neck, and then there's the stone right here. So again, being undergained is really going to impact your ability to pick up stones. So again, kind of harping on gain with our learners. What sign is this called? Yeah, so the wall echogenicity sign. So how do you tell the difference between this versus this? Do you know what this one is? So this is a porcelain gallbladder. So there's just a calcified gallbladder wall. And so if you notice here with the west sign, you actually do see a bit of the bile,
Mhm.
right? And then you see the stones here. It just, you don't see anything, right? There's no bile to see. It's just shadow. So it's just a little bit nuanced. But sometimes a west sign can be mistaken for the porcelain gallbladder or vice versa. All right, what do we got here? Yes, gallbladder, sorry.
Stone, but there's no shadow, right? So just the other way.
It's a polyp. Polyp. Yep. Correct. Yeah. So most of the time, a non-shadowing little growth within the gallbladder is going to be a polyp. Really easy ways to tell, right, is if it's not dependent. So if it's like up here in like the top of the gallbladder against gravity, what are some other ways you can figure out polyp versus stone? Yeah, right. So a stone was going to give you that twinkle artifact. Polyp, depending on size, might actually have some vascularity to it. So that's another way. What's another one? Yeah, exactly. Right, movement. So if you roll this patient, that's going to stay in the same spot. Polyps start to become an issue when they get really large. So you can look at this as what we call a pedunculated polyp, where it looks like it's on a little stalk. This is a sessile polyp, which is a little bit flatter. So depending on the size, so usually a polyp more than 1 centimeter is going to have a higher risk of malignancy, and those require close follow-up. If you find a polyp, you should get some sort of official scanning in the future, you know, could be 6 months to a year.
Yeah. Martians.
Yeah. Again, you can put color flow and look for internal vascularity. So some ways to tell the difference between benign and malignant polyps. So again, benign, they're going to be small in size, they're going to be pedunculated, they're going to be multiple. Whereas malignant, they're going to be larger and then solitary. Those are the big ones. Benign can have a common tail artifact. Yeah, it's usually, I think it's cholesterol deposits in there. Yeah. What about this one?
Is there a little bit of free fluid around the like anterior wall, with the posterior wall? It's like a little hazy. I don't know if that's just good or what it's in.
It's like
Your acoustic
side,
or
yeah.
It's just like there's something there.
This is what we call side lobe artifact.
Okay.
So people smarter than me can explain it, but so this is actually a fake out. This is a hepatic vein that's tracking right along the gallbladder. And so what can help you figure it out, again, is color flow. So you can see there's flow within there. So again, this is one of those where we saw they had right upper quadrant pain. You didn't see any stones, but they had this, which was like, that wall looks really thin, right? So it's really weird to get pericholecystic fluid from cholecystitis and have a thin wall.
Yeah.
Because it goes thickened wall to fluid, because basically the fluid, the pressure shifts into the wall thickens and then leaks through, and then you get the fluid.
Yeah.
So when you have fluid without a thickened wall, then you're starting to think maybe this is ascites, maybe this is CHF, maybe this is, you know, something else or something vascular. All right, what about this one? What artifact are we seeing here?
Yeah.
Edge artifact, yeah. So this is also a common fake out for stones, especially in beginners, right? They're going to see that, they're just looking for the shadowing, and they say, oh, there's shadow, so there must be a stone sitting here that I can't see. As opposed to this one, what's going on here? Yeah. Yeah, right. Oop.
Shadow.
Yeah. So this guy has lots of little pebbles,
Yeah.
right? And so this is a common miss, again, for learners, because you'll see it's bright. So they're like, oh, there's posterior acoustic enhancement. But again, teaching them to track their eyes all the way down. This is just an example of twinkle artifact in a stone. You can see that stone kind of lit up. I think this was your study, actually. And then here's an example of somebody moving. So you can see that stone is rolling. So even though this didn't have a lot of posterior acoustic, shadowing with that stone, you can see that it actually was a stone because it's rolling. What about this one? I find this a lot. It always takes me a little while to like figure out. So this is bowel gas. And so a lot of times bowel gas can definitely be a fake out for stones. And so this is where approaching from different angles becomes really important to help try to figure out, is this stone with shadowing I'm looking at, and this is in the gallbladder, or is this extra gallbladder and just bowel gas? Do you know what this thing is called? And is that pathologic or normal?
That's not.
Good.
What is it? I know what it is.
Yeah.
What the actual name for it is.
Ah,
That thing with the little.
Yep. Yes, the pharyngeal cap. All right. So this is the adenomyomatosis, right? And so essentially what it is you get cholesterol deposits built up in the gallbladder wall, and you get these focal areas of like comet tail artifacts. There you go.
And I was just
There
standing
you go.
residence and we were like, it's B lines, and I was like,
Yeah.
oh. And then I went home and the stuff, like the official was done. And I like was reading about this, about the B line, like a comet tail, so that,
Yep.
yeah.
Yeah. So what can happening, they get these little outpouchings. So it's a hyperplastic condition, which the epithelial lined outpouching forms within the gallbladder wall, and they can collect bile, sludge, or cholesterol crystals. And it could be focal or generalized wall thickening. And then the ring down artifacts from the cholesterol is really common. What would this sort of be confused for? Do you know? Okay.
Must be confused. Trying to think of like we could have like a little bit of a line like that, if you have like air.
Air. Yeah. So emphysematous cholecystitis. Yep. So this is your adenomyomatosis here, right? So you have the little ring down artifact. And here you have air in the gallbladder wall. So if you notice, what's the difference between these two? Here's another example.
That's a shadow. It's going pretty far down.
Yeah, right.
And then adenomyomatosis doesn't very short.
Yeah. Exactly, right? Because this is air. So air is obscuring your view, right? So you're getting that dirty shadowing and basically can't see anything deep to it. Cool. Nice. This is another example of the side lobe artifact. I will refer you back to your artifacts lecture for the etiology of it, because I can't explain it well enough. But again, so what can side lobe artifact get confused for? Sludge. Yep. And then this is which one? Side lobe or sludge? Yeah, right. And you can see there's kind of a clearly defined layer here, right? And there's some like tomofactic stuff in there. There's another example of sludge. Again, lots of goos in there. So sometimes sludge balls can take on this weird dense polypoid looking thing and be mistaken for malignancy and polyps. So this was a tumefactant sludge ball on a patient that actually came in as a trauma. We were just scanning them for practice. And I was like, I think you need an official ultrasound. That doesn't look normal. And it just came back as a sludge ball. So again, ways to figure out if this is a tumor is color flow versus a sludge ball. Yeah, cool. So moving on for bile ducts. So again, we talked about color flow, CBD, normal, right, less than 5 millimeters. For every decade over, you add a millimeter. And then if they've had a cholecystectomy, it should basically be less than a centimeter. Just for speed of lecture time, some differentials for dilated CBD. Most common one is going to be your impacted stones. Other ones are going to be strictures. More serious ones are going to be things like pancreatic cancer, biliary cancers, cholangitis, pancreatitis, and then if they've had biliary surgery. So putting color flow on is super helpful. Again, especially when you have something that looks as big as the portal vein, that's going to clue you in into now that you have some dilated CBD. Do you know the name of the sign? Couldn't get like the best picture of it. It's probably as good as I can get. Where you have the double barrel from your portal vein and dilated CBD. Double barrel shotgun sign.
I was gonna say shotgun.
Yeah. Yep. What do you think this is? So where are we? Let's try to anchor our landmarks. Yep. Liver tip here. Nope, not gallbladder.
The IVC.
So no. So here's SMA. So we're above the SMA. So what vessels are on top? Yep. So splenic, and then there's your portal here. And then what lives on top of the splenic?
On top of the splenic is the
Pancreas.
Like stone or pancreas or shadow.
Yeah, there's a stone within like the pancreatic duct CBD area. Yep. And then again, twinkle artifacts, so color flow on there. What do you think's going on in this one?
Like the. Oh, those are some ones. There's like some shadowing like at the end. I just can't see a stone.
So what if I threw color flow on there? Now what do you think's going on?
It doesn't look like portal. No, it just looks like that's just like all.
Yeah.
That's that big.
Yep, this is intrahepatic biliary dilatation, right? So this is your Bill. So have you ever, they call it the antler sign because it looks like antlers from a deer. Right, so that was this patient's CAT scan. You can see this is all his biliary dilatation. And it was from his pancreatic head tumor. Other things that can do it is cholangiocarcinoma. And then rounding out the last of the bile stuff is, what do you think this is? Yep, yeah, so you got pneumobilia. You guys doing okay? All right, so we're gonna move on to liver. This is like the bulk of the lecture. So normal liver. Um, all right, so when it comes to looking at the liver, it should be pretty homogeneous. Should be about similar to the kidney, maybe just a touch brighter. It should have a pretty smooth capsule. The walls of the vessels should be pretty bright and easy to define, as well as the diaphragm. And this is going to come important when we talk about fatty liver disease. And then the the liver itself should be pretty smooth in contour. When it comes to size, if you measure it along the midclavicular line, and you do from the superior dome to the tip, so you're just going to kind of find the longest diameter. It should be less than 15.5 centimeters. One of the things you can do just for eyeballing technique, right? If you look at the kidney should end after the liver tip. So if you have something like this, where the kidney is here and the liver tip is extended well beyond it, right? This is hepatomegaly. So you can just eyeball it as well, and you don't necessarily have to measure it, which is a nice little pocus trick that I love. Sometimes, however, there is this thing called a Rydell's lobe, where you get a little bit of a growth of the lobe of the liver, and this can be mistaken for hepatomegaly, but it's not. And if you kind of come back and you notice how this liver tip, it kind of comes up, this is a little more pointed, and here it's like a little more rounded and coming down. So there's a little bit of a different morphology to it. All right. Liver masses. What's this one?
So like.
It's the same thing as this one. We see them in the kidneys all the time. Yeah, yep, just a liver cyst, right? So smooth walled, anechoic, posterior acoustic enhancement. Nope, we'll go over it. Here you can have multiple liver cysts. So you can see some septations. Again, this is probably somebody who's polycystic. This probably won't see here, but this is a hydatid disease. This is what we call the water lily sign, where it looks like a water lily. This is usually from like a mature cyst that's the membrane gets like detached from the endocyst. This is another hydatid cystic disease. Again, multiple interloculated cysts. What do you think this one is? Yep. Exactly. Yep. So irregular, hypoechoic, thickened, poorly defined, variable echogenicity within there, right? Here's some more examples. So again, this is normal. And then again, this is abscess. So a little bit hard to see, but again, you're just looking at the difference in the echo texture. And then if you threw color flow over this thing to try to figure out, is this a mass that I'm looking at, like hepatocellular carcinoma, or an abscess? If it was a mass, what would its color flow do? Yeah, right. They would have internal flow to it. If it's an abscess, it wouldn't. Here's another example. Again, abscess. All right. So now what's this one? That's an hemangioma. So a cyst was anechoic, right? And hemangioma are always going to be hyperechoic. What would be some of the differentials for hemangiomas? So this is the most common benign liver cyst, liver lesion. Mets. Yeah. So Mets can both be hyperechoic or anechoic. So this is Mets, but what do you notice different about this one? That like this hemangioma versus these Mets.
Not like super well defined.
Yeah. And so there's multiple, right? And then if you notice this one specifically, it's like eating into the tissue and the architecture, right? Eating in towards the kidney. So it's not respecting the boundaries or the capsule and the border of the liver. What about this guy? What do you think this person has? These are also Mets. Yep. This was yeah. Yep. So Mets can either be hyper or hypoechoic. This was a really heartbreaking case, and like so much of the power of POCUS. It was a gentleman who came in for his third ED visit for kind of pleuritic-ish, right, very upper, like almost chest wall pain. He had gotten a chest x-ray, which was normal on the first workup. The second workup, I think he got another chest x-ray, and then like some COVID testing, and then sent home. And then we just happened to be scanning. We're like, oh, we'll just take a look at your gallbladder. You know, right-sided upper chest could be biliary colic. And then this is what we found when we looked at his liver. And then so putting the pieces together with he'd had a cough for a while, he'd had some weight loss, he had pleuritic upper right abdominal, right-sided chest pain. This ended up being lung cancer with widely metastatic. And so this actually did change his workup a little bit because he went from getting a CTA to basically like a full pan scan for a metastatic workup. So common causes, of course, sources, colon cancer, breast cancer, pancreatic cancer, lung cancer. This is a hepatocellular carcinoma. Again, can look like an abscess. Again, put color flow on it. This is gonna be in like your cirrhotic patients is generally where it comes. You're gonna get your liver findings of cirrhosis. So it's gonna be more condensed. It's gonna be brighter. It's gonna be irregular. Usually there's gonna be some sort of ascites. And then here you're gonna get the peripheral halo of hypoechogenicity. So you can kind of see that it's a little bit blacker, darker, kind of around that mass. And here's another example. So again, darker around that mass. But again, you know, honestly, if you find things like this in the liver, they should 100% need to be referred for official radiology testing. Here's another example. So this is crazy liver of cholangiocarcinoma with Mets. These are more just liver Mets. I think this was a patient who had lung cancer, whose liver was essentially just replaced with cancer, or breast. I forget what her cancer was, but again, more just big giant Mets. All right. So sometimes they're going to be rounded, well-defined. The big thing is you're going to get mass effect, and there's going to be distortion of the surrounding vasculature and tissue. You can get hypoechoic, and then you might have that sort of darkness around that lesion. If we go jump back to this guy, right, you can kind of see there was like that hypoechoicness around the met. That's going to be another clue. Same thing here, kind of hypoechoic around that. And then a lot of times they're going to be very mixed echogenicity, bright, dark, calcified. All right, fatty liver disease. So on the spectrum, right, you get, we're talking about just specific to non-alcoholics. You start with what's called NASH. So that's your non-alcoholic steatohepatitis. And that's where you don't have any changes in the liver enzymes, but you have fat within the liver. And then it will migrate over to what we call NAFLD, which is the non-alcoholic fatty liver disease. That's where you actually get damage from it. And then that will lead over to cirrhosis. You can have two forms of fatty liver disease. It could be focal or diffuse. So focal can be mistaken for hemangiomas or METs. But if you notice here, focal is always going to live around vascular territories, and it's not going to disrupt the vasculature, right? So it's not going to kind of compress or anything like that. Here's another example. You can see right along the portal triad area, this area of focal hypergenicity. Yep. So around vessels, but it's not like eating into it. It's not compressing. It's respecting the boundaries of that blood vessel. It's a vascular flow thing because it's the liver supposed to pick up the fat and the triglycerides and LDLs and cholesterols from the blood. And so it like migrates from the vessels out. So this is diffuse. So we talk about the echotexture from the liver, right? And now it's brighter than normal. If you notice, this is like a bad example, but you can see here's kidney, and the kidney looks quite a bit darker. And then now like here you can see the vessel walls pretty well, but here you kind of start to lose that distinction. So basically what happens is the renal cortex starts to appear darker than the liver. And then if you compare the liver to the spleen, the liver starts getting brighter than what the spleen looks like. That's a nice like comparison. You're going to lose the echogenicity of the blood vessel walls. And then as you start to get worse liver disease, fatty liver disease, right, you start to lose the diaphragm. So sometimes we're scanning patients and you guys you're like, where is this patient's diaphragm? And sometimes this is why you can't find it, is because they actually have fatty liver disease. And then if you go back, you can start to notice the deeper portions of the liver start to become a bit indistinct. So there's 3 different grades, grade 1, grade 2, grade 3. And so essentially for grade 1, you're going to get the increased echogenicity, but your vasculature is going to be kind of intact. And then you can see the diaphragm pretty well still. Grade 2, you start to lose the differentiation of the vasculature. You lose the bright walls around it. And then the echogenicity of the deeper parts start to get a little duller. Same thing here. And then grade 3, so you get bright, you lose the blood vessel differentiation. It gets darker as you go further down towards the liver, but now you've lost the differentiation of the diaphragm. So there's a nice example. So this is normal. Again, grade 1 is here. It's just a little bit brighter. Grade 2, you've lost this differentiation here. And then grade 3, right, this almost looks like cellulitis to me. Just like homogeneous. It's just gray. It's indistinct. Hard to really see stuff.
Any size difference in the liver?
Usually we'll get, if it's diffuse, it'll be a little bigger too. Oh. Cirrhosis, I think I feel like it's one of those where when you see it, you know it, but to peg it down, it's a little bit harder. But again, you're going to get this kind of diffuse echotexture, right? So instead of being nice homogeneous, now it's a little bit more speckly. It's going to get more condensed and shrunken looking. So you can get atrophy. And then it'll get nodule, like lumpy bumpy. So lumpy bumpy. Other things you can look for are signs of portal hypertension. So your portal vein is going to become dilated, so more than 13 millimeters. You're going to get a decrease in the velocity of the portal venous flow. So if you spectral Doppler it like you do for your VEXA score, the flow is going to be lower. It's just slower. And then you might get more of pulsatility to it as well. And then finally, obviously, you can potentially get ascites. When it comes to obviously, we can't figure out exactly the different types of ascites, but if it's basically completely anechoic, it's probably things like cirrhosis, CHF, peritoneal dialysis. It's a lower protein content. Same thing in the lungs as well. If you're starting to see like gook in there and floaty stuff, it's usually higher protein content. So you're looking at malignancy, infection, can be blood. Again, fresh blood will be black. Older blood is going to be darker. All right. Hepatitis. So this is what they call the starry sky appearance of the liver, which to me can look like pneumobilia. This is not a very sensitive nor specific sign of acute hepatitis. The best sign is you're going to start to see is actually thickening of the periportal vessels. So here you can see this is the portal vein, and you can see how thick this area is right here. Other things you're going to get is hepatomegaly. You can see how this liver is really like gnarly. It's like bright and it's dark, and there's some edema around the periportal area. The other sign you're going to get is this gnarly looking gallbladder. So it's going to be super thick, but it's not going to be painful. So they're going to have a negative sonographic Murphy's. Generally, if they don't have stones, or obviously there's going to be no stones, but you're going to get a lot of weird thickness and pericholecystic fluid, but this is not going to hurt them. So signs for hepatitis, hepatomegaly, you're going to get that starry sky again, poor sensitivity and specificity, gallbladder wall thickening. So this one, so big liver, funky gallbladder, and you're going to get edema around the periportal vessels. Those are going to be kind of your biggest ones. The other thing you're going to look at is your portal vein size. It's going to be normal as opposed to the someone with cirrhosis where it was dilated. All right, we're almost done. So approach to jaundice. So when you're asked to scan somebody because their LFTs are up, it's nice to have sort of approach that you're looking for. So the first thing we want to do, right, is we're going to look for and think maybe is this hepatitis. So you're going to find your portal veins, and you're going to look to see is there any periportal thickening, right? And then is the liver enlarged? The next thing you're going to do is you're going to measure the width of the portal vein. So if it's more than 13, you're looking at a cirrhosis probably. If it's less than 11, now you're looking at normal portal vein size, so probably in the hepatitis region. The other thing you can do is put the pulse wave on, and if it's cirrhosis, you're going to get that slower flow within here. So trying to figure out, is this cirrhosis and elevated LFTs I'm looking at, or am I looking at a hepatitis, right? The next thing you're going to do is you're going to try to find your CBD, and you're going to look to see, is this obstructive jaundice? So if the liver looks fine and there's no signs of cirrhosis and there's no signs of hepatitis, now is this some sort of external compression of the CBD area that's causing this jaundice? So again, here's my portal vein. What sign is this called again? Yeah, right. So here's my portal and here's my CBD. So again, if my CBD is essentially the same size as my portal vein, it's dilated, if you want to just eyeball it. Again, things that's going to cause CBD dilation is going to be your choledocholithiasis, pancreatic masses, strictures. Eventually, if you don't relieve this obstruction, the next thing that happens is the obstruction then goes to the intrahepatic biliary ducts. So things that can cause this could be your primary inflammatory conditions like sclerosing cholangitis. You can get hepatic masses or cholangiocarcinomas and biliary duct cancers. Again, to confirm this is biliary dilatation, you're going to throw color flow. And again, these should not light up with flow because it's bile, right? And then we talked about looking for cirrhosis. And then again, just a reminder for hepatitis, right? Periportal thickening. And then you get that gallbladder wall thickening. So again, for cirrhosis, for jaundice, you're looking at the liver, figuring out hepatitis or a cirrhosis. If it's neither one of those, then you're going to start looking for at the CBD and then looking for intrahepatic biliary dilatation. Cool. That's all she wrote.
Thank you.